the signs, clinical signs of tension pneumothorax, you must be aware of this situation and you must be ready to remove the problem. Severe respiratory failure, another thing, when you start to breathe, to hear, you may hear quick, breath sounds, tympanic resonance, low lung compliance when you are ventilating with mask, and asymmetric chest movements. Of course, clinical signs are also shock and dilated carotid veins because of difficulties or venous return from the head. And tracheal shift. Trachea is not in the medial line. It is shifted on the opposite side with the pneumothorax. So, as I thought, you must be aware of this. Here is the pneumothorax. On which side? Here is right, here is left. Anybody? Can you see? Left side? Here is right. Here. So, anybody see? It's obvious. Here. Here is the collapsed lung on the right side of this picture. You must remember when you see the X-rays of lungs or anything else, the darker shadow, the more air, the brighter, the more bones. So when you remember this, you will be at least most importantly see. So here is the part of the chest without lungs and lung tissues. Only guess. Here, I'm sure everybody sees. Here is only gas, as I thought, the darker, less any other tissues than gas. So here is pneumothorax, and here is the thoracic drain to remove the excessive amount of the gas. So here everybody sees, and clinical signs. Sometimes we have to do also with subcutaneous emphysema, and it's when you may find and feel air in subcutaneous tissue. It is enough to touch such a patient. You may feel the crepitations of the tissues. And how it looks on the X-rays. As you see, here are muscles and vein. This is an additional dust. It's a classical subcutaneous emphysema. So, what is the possible method for doing something with tension pneumothorax? Especially tension pneumothorax is important. All others lead, of course, to respiratory compromise, but generally the second part of lungs is, of chest is enough to provide the adequate ventilation. But pneumothorax is a state of immediate emergency, immediate life-threatening emergency, and must be released. Which way do we release tension pneumothorax? You must only find, generally, we look it in the second intercostal space. Second intercostal space on the upper part of the third rib. Why upper part? Because when you see here, there are two, or rather three important structures. Artery, vein, and nerve. So, in order not to get additional damage, especially, it releases to artery and vein, not to damage, you put here the needle. And opening the change the tension pneumothorax to open pneumothorax, which is much better tolerated. Of course, it don't resolve everything, but it gives some time for the patient. Another thing, sucking chest tube. As you see, during inspiration, there is an additional leak of the air through the chest wall, and here, during the expiration, it goes down, so it goes out. So the gas exchange is, of course, worse than normal. So the simplest way, when you see the difficulties of ventilation of the patient, the simplest way, as you see, on the dress temporal seal, these are three parts, and therefore allows for releasing. So now, during expiration, the patient, it is the chance for closing, at least partially, the suction chest. Flyer chest. Oh, what I told you. When you see two or more ribs, adjacent ribs, fractures at two or more places, and the part of chest moves independently. Another, it was related to the chest wall. The most important organ in the chest is, of course, heart. Everybody agrees? So, as I see, girls agree, then the problem with heart is post-traumatic cardiac tamponade. What is? It's the situation when there is an additional blood between pericardium and cardiac mass. The heart can't relax properly, so the amount of blood which is pumped during each strike is lower. So it's also another immediate emergency. Symptoms, classical, Beck's triad, so carotid veins dilatation, silent heart sounds, and hypotension and tachycardia. Those three so-called Beck's triad. It's the first most important clinical symptom of traumatic or not traumatic cardiac tamponade. Another, low electrical voltage in ECG, paradoxical pulse. Generally, pulse on the radial artery is rather steady. When you see cardiac tamponade, during inspiration, the pulse is lowers, during expiration increases. So you may feel that it's different according to the respiratory pattern of the patient. And of course, clinical signs of shock. Here you see the cardiac tamponade. Here is blood, and here is dilated carotid vein, which is another thing, as you see, cyanosis of the patient, especially here. The only possible way to remove is, of course, removing the excess of the pericardium. All right, abdominal trauma. As you see, statistics, 1 for 25% of those patients needs laparostomy. The most common problems, gut perforation, and in the next step, infection. Liver rupture, it leads, of course, to hemorrhage. Spleen rupture, also kidney, sometimes may lead to retroperitoneal bleeding. Here is classical patients with blunt abdominal trauma. Here you see traces after what? And here, as you see, now open. Here, penetrating abdominal trauma. And here, when you may suspect and what? Here, liver in upper right quadrant. In upper left quadrant, So here are situations when after, especially after training, what you should suspect. And here, few words about the practical aspects of your classes. You will, of course, practice everything. One of you will be the victim, or others will work as a rescue team. So the standard care after trauma victim is, of course, having its own special algorithm. Those algorithms were introduced by basic trauma life support. So it was the organization which changed its name in 2006 into ITLS, International Trauma Life Support. So it's why the general scheme for care after trauma by patient, general equipment of ambulances, and skills of rescuers are generally similar. Why? Because the protocol is everywhere the same. So first step is, of course, scene size up. When you go out from the ambulance, you must look at isolation. Of course, you should wear gloves, mask, and assess the safety of the place, number of victims, and what is needed. You must treat as general the rule: one rescue team for one victim. When you see many victims and only your first ambulance, you start the protocol for massive casualty incident. It's absolutely different. Here is not treating everybody. It's assessment and choosing persons with highest chances for survival. But in other situations, general rule is one rescue team for one victim. And mechanism of injury which may allow us to predict the problems we will have during care of the victim. So, as I thought, predictable pattern, because forces applied to the body lead to similar lesions. So it helps you to key on most probable victim. First part, initial assessment. General impression, your feeling on the patient state, the priority of transport. Level of consciousness. I told you about Glasgow scale, but generally, during first assessment of trauma victim, you divide according to ADPU. So only 4 classes: alert, verbal response, fine response, or unresponsive. And you assess according to the score for the 4-degree scale. And the first step, and you, I'm sure, see this everywhere, for instance, on football stadiums. What is done at first with anybody which is after any fall? Immobilization and the cervical collar. Why? Because it's the first step to immobilize and to prevent any other injuries when you suppose have to do with cervical spine fractures. Another step, airway opening. If opened, everybody is good. If not, fixing the airway. Another step, assessment of breathing. So not the algorithm for cardiac arrest. Breathing on breathing. Here, when patient is not breathing, the first step is intubation. Rate, quality when spontaneously breathing, interventions. Oxygen or back of mask, circulation, and assessment assessment of circulation. You should compare with one hand carotid artery with second hand radial artery. And if when you can feel on radial artery, it means the blood pressure is about 80 or more. Below 80, 80 systolic blood pressure, the radial pulse is generally impalpable. The carotid artery is about 30, 40. It's the moment when you can't feel the blood pressure. So when you can feel here in carotid artery, and you can't feel pulse in radial artery, it means that the patient is in deep shock. No matter if it's his or her level of consciousness. Another thing, skin, the temperature, color, condition, and of course, if there are many external, major external bleeding. If yes, the stopping of the bleeding is of high priority. Another step is, of course, critical decision. Load and go when you do rapid trauma surgery, or you stay at the place. When you stay in the place, it's the protocol focused trauma surgery. But rapid trauma surgery, you must recognize all important problems before you start the transport. It shouldn't take more than 1 minute. So let's go. With, as I told you, 2 minutes according to protocols. Of course, believe me, the good rescue team can do it in 1 minute, and it's a quick scan of whole body, and it must identify all life threats, and it is used to note injuries which must be fixed later. So first, it's a mnemonic. What are you looking for? Deformities, contusions, abrasions, punctures, penetrations, burns, lacerations, swelling, tenderness, instability, crepitations. DCAP, DLPS, DIC. So let's go. We go from the head. The head, we are of course looking for all of these changes. We examine the facial bone with palpation. We should look at ears, nose, mouth, any fluids. What are we looking for? Cerebrospinal fluid, as I told, cerebrospinal fluid leak from nose, ear, etc. It's first sign of basal skull fractures. Second, it means that the fractures are old. So important information for the hospital team. That is the patient of special risk for central nervous system infection. Another thing, vital signs, recognize what was shown earlier. Neck. The next step is visualization neck for also PCAP, DLPS, TAP. For tracheal deviation, as I told, the sign of tension pneumothorax. So immediately should be released. Jugular vein distillations, palpation, the back of the neck, and as I told, stabilization was the first step without collar. Here is the next step. After examination, we made the collar. Next step, chest. The set, visualization for all seen and palpable deformities, breath sounds. I know, I hope everybody of you has his own stethoscope in advance. If not, you will have an occasion to take this and check. It's the general. If breath sounds are hearable and are similar on both sides. It's the only thing you should be able to do. Palpation of the cheek, open wound, flared chest. It is it's a moment to take care afterwards. Abdomen, the same, DCAP, etc. Palpation for rigidity, guarding, illness alert and tells you should leave this area for the last part of examination. Pelvis, also DCAP and etc. How do we do it with pelvic bones? Like a book. Close, try to close, try to open. When you see that it's unstable, you know everything. What is obvious? That about 2 liters of blood are impelled in general. So it's enough to recognize shock and start treatment. Lower extremities. So as you see, it is going from head downwards to the lower extremities. Also, you should visualize, palpate, check for pulse, motor sensory function when the patient is conscious, capillary refill. And after lower extremities, you go to the upper extremities. The same. Visualization, palpation, feeling the pulse, motor sensory, capillary refill. And at the last, rolling and examination of the body. Not only the anterior part of the body. Turn, roll, and check the back for all deformities from neck to legs. And when the patient is rolled, you put the how it is in English or what? The device for transport under the patient. You immobilize the patient on this and go on. Starting from body, after that you secure the head and you reassess mental state of the patient. If it's better or worse than during initial examination. So the summary. First scene, you look everywhere. BTLS, primary survey with initial assessment and rapid trauma survey or focused detailed exam. Critical interventions. The critical interventions I showed you, the set of most important things like tension pneumothorax, stabilization of bleeding, etc. Time for detailed exam, and this should take place in the ambulance, not on the scene. And ongoing, you must reassess the patient's state because they are dynamic states in clinical settings. Pitfalls, most important, approaching before performing a size up. It may be dangerous for the rescuers, and everybody knows that rescuers helps nobody. So you must be sure of your safety. And another thing, trying to do too much at the scene is generally not the best conditions. The most effective in helping from victims of trauma are, of course, specialized centers, hospitals with full provide equipment and staff. And when you are at the emergency department, short, concise report, mnemonic mechanism, injuries from head to toe, neurological exam with Glasgow Coma Scale. Time for Glasgow Coma Scale assessment is also in ambulance. It's the part of detailed examination and treatment performed and vital signs. Vital, everybody knows what's vital. What's vital? Respiratory rate, heart rate, blood pressure. That are vitals. All right. And here is the patient in emergency department, and to tell the truth, the operation here is the vaporizer, sevoflurane, anesthetic machine, and